Welcome, welcome, welcome to week 10. Yes, we are over the hump. Okay, YouTube coders, this week we will be diving into CPT Integumentary. What is that? Well, we're going to explore skin, nails, hair. Yeah, I guess hair and related procedures from wound repairs, excisions to skin grafts and biopsies. You will learn how to accurately apply CPT codes for integumentary services. And you're going to learn these guidelines. Now, we can't cover all of them, but we will do our best to give you the tools to delve into the guidelines yourself. All right? Okay, coders. So let's keep that momentum going. Let's do this, but not before we greet our team. Yes. Say hello to the AMCI Dream Team. Yes, Mr. Sandeep. He's our curriculum developer. Ms. Dolly, she's a lead instructor and editor. Ms. Bianca, she's a lead instructor and student success manager. And let's not forget about Ms. Mills. She's also a lead instructor and intern manager here at AMCI. And they also have other roles too. But as it pertains to this YouTube course, this is what they do. At AMCI, we have a team they're more than just a group of instructors. We are dedicated mentors, industry experts, and passionate educators. And we do the work. We study just like you. All right, let's not forget our interns. Say hello to the AMCI interns. You know them. They are wearing the blue badge and they're more than just our students. A lot of them are already certified. They are seek to be dual certified. So a lot of them have their professional certification or they're very close to it, and they are emerging leaders in the world of medical coding. Each intern has demonstrated exceptional dedication, a commitment to mastering those guidelines, and a passion for forensic coding. And you know what? They are here for you. And the best part of it all, they love it. So please say hello to the interns. I know that was long, but I felt they deserved it. Okay, so we do have a disclaimer. All right, so if you're not familiar with CPT coding, you're new at this, we recommend that you view the beginner's lectures before moving on. Also, I recommend that you join the I2MC course, Introduction to Medical Coding. If you are a true novice. It's free. You don't have to pay for anything. Go in there, get the foundations, then join the YouTube course. It will be available after we are finished. So don't worry. All right. So this is the playlist. Team, can someone drop the playlist for this introduction to medical coding? Please and thank you. So, what the heck is going on at AMCI? What are you doing? Well, as it pertains to you, YouTube course students, it's in the Discord. You know what? I attended that AMCI Friday Night Live, that game night last week. OMG. They played, of course, Jeopardy, Hangman, and then they introduced the Wheel of Fortune. You know what? Get in there, get in there. That was fun. Also in Discord, our introduction to I'm Tap. That's interactive medical terminology and anatomy and physiology. This is fun. You don't need books. You're going to learn medical terminology and anatomy in a fun way. We found that our students like to play. So there you go. Play, play, play. And this is one of our most popular classes. And it's in Discord. So you got to join Discord. All right. Weeks 9 through 16, these are the books that you'll need. Your HCPCS Level 2, CPT 2025, your Bucks Step by Step, and your MCG manual. So go ahead and make sure you have them. And today, we're going to focus on that CPT 2025 as well as your MCG. You're going to see clippings. All right. Now, there is a discussion that we need to bridge. And, a lot of people, not most people are cool with this course. And some people are like leery, like people are telling them, and possibly competitors, I think I've seen it, are saying, hey, don't go to that free course because they're going to make you buy something. Heck no, you better not buy anything. Yes, the MCG is a required manual. It's required because it's doggone good. However, note that we show you, if you can't afford it, we show you how to get the material on your own. When we're pointing out where the guidelines live, that is how you get the material on your own. So you don't even have to buy the MCG manual. However, there are practice exercises in there. It is a useful tool. I wouldn't steer you wrong, but if you do not get that MCG manual, you can still take this course. You can still pass the medical coding certification. I will show you how, and I will give you as much as I can. So, why are you doing this, AMCI? Why are you providing this free course? Because we want to give access to high quality medical coding education to everyone. We want to address critical gaps in medical coding education. Yes, we see them. We see those gaps. The competitors are missing some things. You're not teaching in depth medical coding instruction. You got to do that. You do. And I'm going to tell you why we're doing that. Also, we want to model ethics and excellence. Coders, I know that there are some unethical things that happen. Many of you, we hear your stories, we read your stories every single week. We see them coming through, and I'm going to show you some of them. And we do know that some of you have been done wrong. You've been charged for medical coding instruction and they did not deliver. However, I see some coders doing some things too. Someone actually photographed the CPT manual and is distributing it. You don't do that. That's unethical. You cannot do that. Do not reproduce any book and distribute it. It violates a law. How are you going to be a medical coder responsible for making sure that providers uphold laws? And you'll see that when you get to CCS because that's what they do and that's what you're supposed to do. You cannot do things like that. So we want to model ethics and excellence. And we assure you that this course is not a tactic to gain more students. Absolutely not. Just so you know, a large portion of our students come from other courses after they've paid them. Yes. So we generate revenue off of courses that are not doing the work and not doing the job. So we didn't feel good about that. After you've paid, then ask you to pay again? No. So if anyone asks, AMCI believes that self study is best. If you can self study and save that money on your own, go ahead, and we are committed to helping you do it. Now, this is what your peers are saying. We just grabbed these off of our YouTube. This person came from a billing and coding program, and the coding did not have enough dedication. They only gave them 1 hour a week seminar for coding. So this is common among colleges and universities. This student says she's in an online class and she came to YouTube because she needed help. Why are you doing that? If you paid for a course, your course should do everything, right? Also, a student took a class twice and I guess she thought she missed something, but she has affirmed that the AMCI free YouTube videos provided her with more information. This student says that her medical billing and coding class didn't do the trick, didn't do enough, and she needed the AMCI YouTube lectures. This student says that the AMCI YouTube videos go in depth, whereas where she currently is or what she's looking at on YouTube, they don't. And she said that, hey, I'm tired of watching these a day in the life of medical coders. But the reason I shared this one because she got 560 thumbs up. So a lot of people agree with her. So she wants in-depth instruction. Also, this person says she's been in a course for a whole year and she's learned more in 40 minutes from watching the free YouTube lectures. And finally, this one says she's paying for a coding course, but she's learning more with the AMCI free YouTube videos. So, coders, this is why we do it. All right. And I got to tell you that the biggest culprits are the accredited institutions that teach medical billing and coding. They are taking your money and they don't often have the correct medical coding curriculum to prepare you for the CPC, CCS-P, and CCS. Now, I got to tell you, the best place for exam prep for the CPC is AAPC. Yes, they are the medical coding certification body. Of course, they have the best exam prep, and the best exam prep material for the CCSP or CCS is AHEMA, right? Yeah, they have the best material. But did you know AAPC is not accredited? So if AAPC is not accredited, when an accredited institution tells you that, hey, you got to be leery of a non accredited institution, what are they saying? You know what they're saying? They're saying, pay me. That's all they're saying. Pay us. Our accreditation says you need to pay us. But if AAPC is not accredited, then what are they saying? And in sum, AMCI makes more revenue off of these accredited colleges and universities. Get it together. Get it together. Get this instruction together, colleges and universities. Stop taking their money. Now, what is the difference? What are we doing here? Well, this course is a medical coding instruction course. That's why we're going in depth. We are not an exam prep course. An exam prep course solely helps students pass a certification exam. A medical coding instructional course is a comprehensive teaching of medical coding. So we're going to teach you the guidelines, we're going to teach you nuances, we're going to teach you how to abstract documentation and code it, right? So this course is a medical coding instructional course, and at the end, we will direct you on how to exam prep at the end. Indeed, and we will use AAPC resources for the CPC exam, and we will use AHEMA resources for the AHEMA exams. So, Some people are saying, hey, don't go to that free course. It's pretty much driving you because they want to charge you whatever, make money off of you. No, we don't. My advice, if anyone tells you that and they tell you not to take the free course and to pay for something else, tell them, sure, I will pay for a course when I finish the free course. And coders, I'm going to tell you, 90% of you will not need to pay for another course if you take this course as outlined and follow our instructions at the end. All right, so I've said it. I'm probably not going to say it again. I'm probably going to get in trouble for telling you. But you know what, coders? It is unethical to take your money and not give you the product. So I choose to give you the product. All right, let's go and let's begin with the copyright. CPT is copyright 2025 AMA. All rights are reserved. AMCI trademarks are keyword concept FTR CHUN, AMCI Fab 7, AMCI ICD-10 CM Flip Tapped, and MCG. CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC. CCA, CCS, CCS-P, RHIA, RHIT are owned by AHEMA, and AMCI does not own the rights to these credentials. Goals of the presentation for week 10. Number one, we're going to introduce you to the AMCI CPT coding annotation technique called CHUN. Number two, we're going to have a brief discussion on the anatomy of an integumentary system. Number three, we're going to discuss how to code excision of lesions, how to code skin repairs, how to code destruction procedures, and Mohs micrographic surgery. And finally, we're going to bring you one step closer to CPT coding mastery. Now, let's begin with CHUN. What is CHUN? Well, CHUN is the acronym for circle, highlight, underline, and notate. It is AMCI's official CPT manual annotation technique. This is what we use to annotate our CPT manuals when we take our medical coding exams. It helps us abstract codes more correct and very, very quickly. Yes, this is AMCI's. Not only do we use this technique, we created this technique and we're very, very proud of it. Now let's get down to the basics. Let's discuss some of the suggested supplies that you'll need when you chun. And we recommend pens. Get some pens. Get black, blue, green, red, purple, whichever you choose. And yes, there are no stipulations in terms of the ink color. Previously, years ago, we were told by Pearson VUE that we could not use black ink. I don't think that was ever a HEMA, but just so you know, you can use any ink. You'll need highlighters. You'll need a primary color. We recommend yellow for your primary color and a secondary color. We're going to use blue, sometimes green, but make sure that it's a pastel color and it's something that works for you. All right? And we recommend the Frixion erasable pens and the Frixion erasable pastel highlighters. Did you know that they're erasable? Yes. So that's why we recommend this brand, but you can use whichever you choose. Additionally, you may want a ruler and a good desk lamp. Now, let's talk about CHUN and the process. As we've said before, CHUN is the acronym for circle, highlight, underline, and notate. Let's talk about what this circle, highlight, underline, notate is. Well, when you're circling, you're going to be circling families. A family is a parent code and an indented code or a dependent code. I will show you very shortly, but you'll need to circle the families. Also, you'll need to include those parenthetical guidelines that apply only to that family. And also, if it doesn't have a family, it's called a standalone code. Just thought I would tell you. Highlight. When you're going to need to use your highlighting colors now. You're going to highlight in your primary color the parent language after the semicolon because it is specific to that code. Also, you'll need to highlight that child or that dependent code, and you'll need to do it in your primary color. You'll also need to highlight all parenthetical guidelines in your secondary color. Also, you'll need to highlight your code level parenthetical language in that secondary color. And I'm going to show you, I'm going to give you an example of all of these. Then you'll need to underline. Underline anything that needs to be emphasized, then notate. You will notate at the top of the page any heading. You know, headings that are in your CPT manual, the blue headings, the red headings, the green where needed. Remember, headings will only appear on certain pages, but they could pertain to pages, subsequent pages. So if we're in a section, let's say integumentary section, right? The subsequent pages won't say integumentary, so you might want to document that heading, and we're going to show you why and how it works. Also, you'll need to notate or annotate your facts to remember or your FTRs at the bottom of the page. We'll show you that as well. You'll need to notate procedure keywords if you choose. Sometimes people just like to underline it, some people like to write it. I like to write it. Also, code level distinguishing keywords. So any keyword or buzzword that really makes that code jump out, you probably should notate it. Now, let's do a demonstration. All right, so now here is an example or demonstration of CHUN, and we're going to begin with circle. We're going to circle families. That consists of a parent code and an indented or child code or dependent code. You know it's a child code because it's indented. You know it's a parent code because it precedes the child and it's not indented. So we're going to circle all families on the page. So we have 10021 family, 10005 family, 10007 family. Now, also, if there are parenthetical guidelines, include them in the circle if they only correspond to the codes within the family. So as you can see, these parenthetical guidelines do correspond only to these codes. Now, if they were pertinent to other codes, you wouldn't do that because you might miss it. If you're taking your exam, you might not see it. So because they are pertinent only to these codes, we're going to include them. And a parenthetical guideline is language within the parentheses. That's what we call a parenthetical guideline. Also, the same is true for the 10005 family, and the same is true for the 10007 family. Now, we're finished circling. Let's move on to highlighting. Now, this is where you'll need to choose a main color, and that main color you will always use for this purpose. You'll also need to choose a secondary color, and don't change them. They have to remain the same. That's what we recommend. All right, so you're going to need to highlight the language after the semicolon. The parent code has a semicolon often, not always, but often. And you'll need to highlight the language after that semicolon because it's pertinent to only that code. So if we're reading fine needle aspiration biopsy without image guidance, first lesion, this is code 10021. That is their language and only their language. So we're going to highlight first lesion so you can see it. You'll also need to highlight the indented code language because it's pertinent only to that code. So, fine needle aspiration biopsy without image guidance. This language before the semicolon is the common language portion. So this means this language is pertinent to all members of the family. It's actually a space-saving technique used by CPT so they don't have to keep writing it over and over. So when we read 10004, fine needle aspiration biopsy without image guidance, we don't have to highlight it because it's common. We're only going to highlight what isn't common to everyone, and each additional lesion is not common to anyone other than 10004. So we're going to highlight it. There you go. So we're going to do that for all of the remaining families. So any language behind the semicolon and the um, language, the indented code language. Now, the next thing that we're going to do is highlight all parenthetical guidelines. All right, so we're going to use our secondary color for that. And parenthetical guidelines is language within a parenthesis, right? So there you go. We're going to highlight it. It's really, really important. Why do we do that? We do it because this is the highest level of guideline in CPT. This guideline will take precedence over almost all guidelines. Almost. And it's very, very important. So you need to highlight it and you need to read it. And you will have some questions that can be answered only if you've read the parenthetical guideline. All right. Also, you'll need to highlight any language at the code level that's in a parenthesis, right? What do we mean by that? All right. So if you look at 10004, there's some language right here at the code level in parentheses. This might not be a parenthetical guideline, but it is very, very important. It's instruction and it is a guideline as well. List separately in addition to code for primary procedure. Important. Important. Okay? So it's an add on code. It's just telling you, hey, you know, you list it in addition to the primary. Now that we've learned how to highlight, let's go ahead and underline. We're going to underline anything that needs to be emphasized, and we're going to highlight language within a family to distinguish codes within a family. All right, let's do that. So we finished circle and highlight. Now let's get to this underline. Right here, 10021, this is without imaging. 10005, ultrasound guidelines and ultrasound guidance and fluoroscopic guidance. So anything within a family that needs to be emphasized. All right. You'll also need to underline language within a family to distinguish codes within within a family. I don't think we have any of that, but if you have it, you'll need to underline. Now, let's go ahead and notate. I like to notate at the top of the page, at the bottom of the page, but I also want to highlight, or excuse me, notate key words relative to the codes. So that's what we're doing here. This is fine needle aspiration biopsy. And this is fine needle aspiration biopsy with ultrasound. And this is fine needle biopsy with fluoroscopic guidance. I can see that at a glance and I don't have to squint at a glance. Now, if you can do that at a glance, how much time will you save? Okay? All right. Also, you'll need to notate at the top of the page the red headings and blue subheadings if there are none. If the red subheading is there, you don't need to write it. But if it's not there, then you write it from the preceding page. Also, you'll need to notate at the bottom of the page the facts and guidelines to remember. And I believe that's it. Yeah. So also there's some additions that I want to bring your attention to. Place asterisks around do not. When you see these do nots, place asterisks or do not symbols because they are key. You cannot do that. You cannot under any circumstance, okay? And also, you'll need to box what we call game changers. When you see and, that's a game changer. It's not like ICD-10-CM where and means and or. No, in CPT and means and. You have to have both, okay? And with is another game changer. Each or and eponyms, those are game changers as well. And we'll show them. You'll see them in some of the instruction later on. But if you're in the CHUN group, you're going to see it. I'm going to definitely demonstrate it. But just be mindful, okay? And another thing I want to tell you, try and keep your highlight colors to a minimum. Don't try to have multiple highlight colors unless you can function like that. Less is more, less is best, and that's what I encourage. Also, you can use whatever color pens you want. I say less is more, coders. Less is more. And if you want to know what I think you should keep that pen color to 3 if you can. Just saying. Just saying. All right, coders. There is my asterisk. These saying do not. Do I have any game changers here? I don't. All right. So, ladies and gentlemen, this is AMCI CHUN. And it actually looks like this in your book. Yeah. And if you are a member of the CHUN group on Facebook, you can see all of your peers' CHUNs who has uploaded it. You can just go to the album. First, join CHUN group. Coders or team, please place the CHUN group link in the chat. I'll also have it on your syllabus and join it. Then once you join, you go to the album and you find the CHUN that you're interested in. And keep in mind, that is your peers' CHUN, and it's good. It is. It is. It's not the instructor's CHUN like we have in the Discord for the gold and platinum members, but it is CHUN. It's a good reference. So go ahead and take advantage. And make sure that you CHUN your integumentary section in your CPT manual. And if you CHUN it before you take your exam, you will see a difference. You'll see that you'll code more quickly and correctly or efficiently. And if you want to test if this is true, test it out for yourself. Go ahead and take an exam before you CHUN and note the time. Then take another exam after you CHUN and note the time. You don't have to take the same exam or do that with a different chapter. You will see the difference. Okay? Now, remember, CHUN the integumentary section. Do it now. Do it after you've completed the assignments. Go ahead and CHUN. And where do you find the FTRs that we've spoken about? You get them from your MCG manual. Yes, those FTRs are outlined chapter by chapter. And if you don't have an MCG manual, we will show you where we get the guidelines from, and we'll teach you how to do it yourself. It's going to be more time consuming, but it is worth it. Okay, let's get started. Okay, we've got a presentation, and this presentation is from our live class. So let's begin. Let's talk about the integumentary system. Today, we're going to talk about excision of lesions. We're going to learn how to repair. We're going to have to code repairs and closures. We're going to learn about destruction, and we're going to learn about Mohs micrographic surgery. All right, so this is the A and P portion, anatomy and physiology of integumentary system. So this is just a basic review. And just to let you know or remind you, the anatomy represents the structure of the body, and the physiology, this is the function of the body. So we're going to talk about both, right? And we're going to talk about the anatomy of skin as it pertains to coding. Well, there's some key or important medical terms that you need to know. And you need to know that epi means upon, dermis means skin, sub means under, and cutaneous, that's also a term for skin, right? And did you know skin is, one moment. All right, I had to get a little water. I'm back. And so, did you know skin is the largest organ of the body? So let's go ahead. We had our little review of these terms. So let's go ahead and use them. When you say, or when we say epidermis, epidermis means upon the skin. So this is the epidermis region right here. Uh-oh. The dermis is the skin. It is the true skin. It is between here. And the subcutaneous is not really skin. It's under the skin. And subcutaneous is also referred to as fat. And when you're coding in integumentary system, sometimes you're going to go deeper than subcutaneous. And underneath the subcutaneous level, you have what we call fascia. And fascia is the wrapping around muscle or that skin. You know, like you buy sausage and there's some encasing or wrapping. That is called fascia. So you get to the fascia before you get to the muscle, and the muscle is before the bone. Excuse me. And I'm gonna let that marinate. Now, also too, we'll be using some other terms like split thickness and full thickness. You know, split thickness means cutting through the epidermis and part of the dermis, right? So you're going to probably cut from the top of the skin to just about here. That's considered split thickness. And when we have conversations about burns and repairing burns and grafts, those burn grafts, we have split thickness grafts, and we also have full thickness graft, and often the full thickness, of course, is the more severe. And when you're coding or speaking about full thickness, we're talking about cutting all the way down through the dermis. Okay. And we can also, sometimes in documentation, you might hear language such as split thickness and full thickness, and in general, in the repairs section. All right, now let's talk about guidelines. Let's talk about CPT general surgery guidelines. So we've spoken about the anatomy and physiology. We've talked about some terms. Now let's know these rules. Now these are general and applicable to all surgery codes. All right, so the CPT, surgical package definition, we've talked about it in your homework. So I'm not going to go too in depth, but this is where they are, and do not forget these guidelines. The surgical package means that every single surgical code in CPT has other items packaged in it. So they include or bundle the E&M services or the office visits that came before the decision for surgery, on the day before the surgery or the day of surgery. So in other words, a doctor can't be paid for an office visit on the day before surgery or the day of surgery. These CPT codes include local filtration, immediate postoperative care, including talking to the family and dictating notes. These codes include writing orders. It includes evaluating the patient in post-anesthesia recovery area and typical postoperative follow-up care. So we do not code additionally for them. Also, these codes dictate how many visits following a procedure that can be carried out without being coded additionally. All right, so what does that mean? That means if somebody comes in and they have a some scopic procedure, the powers that be, namely CMS, have determined that there are no follow-up visits included in that surgery code. In other words, if somebody has a scopic procedure, they come to the doctor a month later, the doctor will get paid for that service a month later. If a patient has a hysterectomy and they have 6 months follow-up period, that doctor will not get paid no matter how many times that patient comes in to see them about that surgery for 6 months. They are included. That's what that means. The same is true for therapeutic surgical procedures. Supplied materials, it basically says that supplies are generally bundled, but sometimes they're carved out. And if they're separate, you can use 99070. And when you're reporting more than one procedure or service, it tells you what you need to do. When you're coding for a separate procedure is often a procedure that has parentheses around it that says separate procedures. And generally, these are coded separately, not with other procedures. However, if it appears, if these procedures are carried out with another procedure, if it's related to that other procedure, you don't code it. If it's unrelated to that procedure, you code it and you append modifier 59. All right, unlisted services and procedures, what you do, there are a list of unlisted services. In other words, if there is no procedure code in the book for it, you are to use an unlisted code. And the doctor has to supply the operative report and any other information that will help the insurance company consider the code. All right, so we talked about surgical package. I'm not going to be redundant, but just remember, you do not code an E&M code along with the surgery code unless there are circumstances, and we'll talk about that later. Don't code the local infiltration, immediate postoperative care, writing orders, or the patient in post-anesthesia recovery. This is what you code for the supplies and materials and drugs, 99070, if you need to, but generally those things are included in the code. And that separate procedure, we already reviewed that, right? So you don't code it. Generally, see that separate procedure in the parentheses? It's generally coded separately. However, if it's related to another procedure, don't code it, right? If it's unrelated, code it and append modifier 59. So separate procedure, for some reason, people get, they get it confused. But I think after today, you all have this. When performed by itself, code it. When performed in the same setting as another related procedure, don't code it. If not related to another procedure, go ahead and code it and use modifier 59. Okay, coders. So if a doctor performed a percutaneous breast biopsy followed by a lumpectomy, how do you code it? Well, this is how you do it. Well, you look up your codes, right? You got your biopsy of breast here, your percutaneous biopsy of breast, and over here you have your mastectomy partial here. So if it's properly chunned, we'll see that this is percutaneous needle core not using image guidance. And beneath it, this is open incisional biopsy. And also in the parenthesis, it says, hey, this is a separate procedure. And also here's some guidelines. Now, if we go over to the mastectomy, we have some parentheses, and it says, hey, this is a lumpectomy, tyletectomy, quadrantectomy, segmentectomy, and we have guidelines. All right, coders, how would you code this encounter? What say you? Good deal. Okay, one person is on it. She is like, yeah, yeah, yeah. All right, so what is the rule? Well, the rule, we want to know, can we code both this biopsy and lumpectomy in the same setting? Well, what is the rule? Well, we see that the biopsy is a separate procedure. However, we will not code it in addition to this mastectomy because it's related. A biopsy of the breast and a mastectomy, that's removal of the breast, they are related. They're in the same body system, right? Right? So if they are related, we would not code it. So we're only going to code the partial mastectomy. Somebody said, aha, I love it. I love it. All right, so now we understand that guideline. I also want to reinforce, because I know I've said it throughout every homework, those homework lectures, that the guidelines, those guidelines have a hierarchy, right? And the highest ranking guideline are your parenthetical guidelines, the ones in the parentheses. The next highest are your chapter guidelines, the ones under the blue bold, and your third highest Those are the green ones, your general guidelines. Now, if they're all applicable, apply them all. But if you have them all in the same setting and they kind of overlap, choose the highest ranking. However, if there are no guidelines, what do? Type in the chat. You guys, somebody is in there rocking away. Outstanding. Outstanding. Two people have answered. I'm going to give you a few more seconds. And if there are no guidelines, use keyword concept. That's right. Somebody got it in at the buzzer. That's what I'm talking about. All right. Are you all ready for coding exercises? You're ready? I'm ready. I've been talking. I want to see what you got. All right, so these are the instructions to solve a coding exercise. Number one, read the last sentence first, then the answers. Number two, highlight or document only your diagnoses and procedures, the diagnoses, signs and symptoms and procedures, and then apply the guidelines. Now, I'm going to ask my wonderful intern, Dr. C, to come to the fore. But before we have her say anything, I got to introduce you to Ace, the AMCI alligator. Ace will be joining us for the rest of the semester. All right, here we go. All right, Dr. C, please and thank you.
All right, coders, pencils up. Are you ready? The question is, which code best describes the encounter? Answers A, 11755, B, 11760 and 11755, C, 11765, or D, 11760. The patient has a wedge excision and a biopsy of the skin of the nail fold. Which code best describes the encounter? Good luck, coders. You have 2.5 minutes.
I do apologize. Someone said, hey, I don't hear you. Thank you so much. So I do apologize. I was double muted. So my key words, wedge excision and biopsy of the skin of the nail fold. And that's the first thing that we need to do, highlight, then we document. Wedge excision of the skin of the nail fold, that's our procedure. And so is biopsy of the skin of the nail fold. It's another procedure. Next thing that we're going to do, we're going to go ahead and look up our codes, and we're going to stop at 11755. This is the code for biopsy of nail unit. Separate procedure. And it's coming up wrong off the bat. And the reason it's wrong, well, some people might not know it's wrong, but it's a separate procedure and it's being coded in the same setting as another related procedure. How do you know it's related, Mrs. J? It's in the same body system. It's on the same nail. But if you didn't know, you can put a little star there and then use your process of elimination. But it's considered related. It's in the same body system. All right? So 11760, this is repair of nail bed. There's no mention of a repair, so that's wrong. And 11765, wedge excision of skin of nail fold for ingrown toenail. All right, so this is correct, right? I wish I had my, you know what, moving forward, I'm going to bring my list over so you can see it, but you can see it here. This is correct. Wedge excision of skin of nail. So 11755 is not going to be coded by itself because it's not coding for the wedge excision. It's not going to be coded by itself in the setting of wedge excision. We're going to eliminate it because it's actually bundled. 11760 is incorrect because the repair of nail bed did not take place. 11765, I like that. And 11760 again did not take place. So 11765 is our answer. And we would not code it in addition, we would not code a biopsy if that was an answer. We just wouldn't code it with this code because they are related. And the answer is C. All right, coders. You all did a great job on that one. A lot of people got that correct. All right, so now we have another exercise. I'm going to hand it over to Dr. C. You did an amazing job before. Please and thank you.
Okay, coders, exercise number 2. And the question is, the correct CPT codes are A, 15822 and 15823 with modifier 51, B, 15823 with modifier 50, C, 15822 with modifier 50, D, 15820 modifier LT, and 15820 modifier RT. A 76-year-old has dermatochalasis on bilateral upper eyelids. A blepharoplasty will be performed on the eyelids. A lower incision line was marked at approximately 5 millimeters above the lid margin along the crease. Then, using a pinch test with forceps, the amount of skin to be resected was determined and marked. An elliptical incision was performed on the left eyelid, and the skin was excised in a similar fashion. The same procedure was performed on the right eye. The wounds were closed with sutures. The correct CPT codes are, good luck, coders. You have 2.5 minutes to solve.
Someone said they're not hearing. That's because you all should be solving. So can you hear me now? Awesome. You know what? I think we have an amazing group here. This is the same group from my part 2 class, and I am loving the participation. You all rock. Okay. Someone said the team rocks. That's what I'm talking about. Thank you. All right. So first things first, dermatochalasis, bilateral upper eyelids, blepharoplasties. Woo! And the same procedure was performed on the right eye. Okay, so bilateral upper eye dermatochalasis, bilateral blepharoplasties. These are my keywords. Now, with my inventory below, we're going to go ahead and select the best answer. And we're going to begin at 15820. This is a blepharoplasty. Correct procedure? Wrong. Eyelid. This is for the lower eyelid. So we're going to eliminate it. We're going to eliminate D. But if you look at D, it's coding for 2 blepharoplasties using 2 codes, left and right. And I'm going to show you why that's wrong. Next, 15823. This is the code for blepharoplasty upper eyelid with excessive skin weighting down the lid. There is no mention of excessive skin weighting down the lid. Nowhere in this documentation. So, if it wasn't documented, it did not happen. So, we're going to eliminate B. And we're also going to eliminate A, too, because it has the same code, gotta go. And that leaves us with C, 15822. And this is coding for blepharoplasty upper eyelid. And if you look below, for bilateral blepharoplasty, add modifier 50. So the answer is C. All right. A lot of you got it correct, and a lot of you had an aha moment. That's what I'm talking about. Outstanding. Now let's switch gears, and we're going to talk about excision of lesions. And the most important thing that you need to know is the difference between benign and malignant. I'm not a clinician. I can't really tell you the difference, but benign is non-cancerous. I can't tell you I can't look at a lesion and say, hey, this is benign and this one's malignant, but I can tell you how to look at a code and you can tell based on the code if it's benign or malignant. Benign codes begin with 114 and malignant codes begin with 116. And that's important to remember. It's really important. 114 versus 116. Benign and malignant. Why? Because this is a multiple choice exam that we're preparing for, right? Yeah. So if we're preparing for the multiple choice exam, oh yeah, by the way, and these fill in the blanks. But if we're preparing for this exam, knowing and being able to recognize and distinguish the benign codes from the malignant, you have an advantage. And if you didn't know, benign codes are non-cancerous, malignant codes are cancerous. And according to CPT, there are some standard ways to consider these codes, but one of the significant things is, well, they're very similar in terms of how to code them, which is good, and also how to code the size of these excisions are also similar. So the formula to code excisions is you have to take the size of the lesion, and that information is given to you. Then you add it to the margins and make sure you multiply the margins, or one margin times 2. All right? And that's going to be your excised diameter, and that's what we code when we're coding for excisions. Now, they do both have both benign and malignant lesions. They have their guidelines, and I've clipped this from the MCG manual. And the way you code benign lesions are, number one, you got to determine if it's malignant or benign. If it's malignant, then you code from the 116 category or code series. You code these lesions separately. You code them according to the body area, and simple closures, like simple sutures, are bundled into the excision code. Now, if you have intermediate closures, you code those. Complex closures, code those. But simple, they're bundled. And the malignant lesions have the same exact guidance. They also include re-excisions. During a postoperative period, use modifier 58. All right, and here's some keywords to distinguish. So if it's benign, non-cancerous, that's benign, 114. If you see basal cell carcinoma, squamous cell carcinoma, melanoma, those are malignant. All right. Now let's go ahead. Are you all ready? Ready for a coding exercise? I hope so. All right. Dr. C. Uh-oh. Let's go back. My inventory's up. One second. All right, Dr. C. Please and thank you.
Okay, here we go. Exercise number 3, third time's a charm. What CPT codes should be reported? A, 11642 and 12013. B, 11643. C, 11643 and 12013. D, 11442. A patient presents to the physician for removal of a squamous cell carcinoma of the right cheek. After prepping and draping the area in a sterile fashion, the surgeon measured the lesion, documenting the size of the lesion to be 2.3 centimeters in its largest diameter. Additionally, the physician took margins of 0.2 centimeters on each side of the lesion. One layer closure was performed. The patient tolerated the procedure well. What CPT code should be reported? Good luck, coders. You have 2.5 minutes to solve.
Outstanding. Great job. All right, first things first, highlight removal. Squamous cell carcinoma, right cheek, lesion, 2.3 centimeter diameter, margins, 0.2 centimeters each side, 1 layer closure. Look at that. Why did I do that? Of course, I'm getting rid of anything. That's right, you guys got it. They said benign. I'm getting rid of anything on site. It is a distraction. Next, I'm highlighting or writing or documenting my inventory. Removal, that is my procedure. Squamous cell carcinoma right cheek, that is a diagnosis. And your lesion size, 2.3 centimeters, your margin, 2.2 centimeters each, because you got to have two. And remember, margins are equal, always the same. And layer closure, that means 1 layer. And we're going to talk about them in a minute. This is my inventory. Now, I need to know, is there an applicable guideline? I need to know. And yeah, there is. There's a guideline for coding malignant lesions. And it says when you see this language, squamous cell carcinoma, melanoma, etc., this is coding from the right section. Also, this guideline here, it says simple closures are bundled into the excision. And we know this is simple because we did our homework. And if we didn't, we might not know it. So in other words, we have a layer closure and it is simple, so we are not going to code it. Now, we're going to go look up our codes. Let's do our due diligence. This 11440, this is a benign lesion. We do not have a benign lesion. We have a malignant lesion. So all codes in the benign section, no matter what the size, are incorrect. And we're going to get rid of it. Now, let's go to 11640 family. This is excision of malignant lesions, including margins of the face, ears, eyes, nose, lips. And this does fall in the right section because this patient's carcinoma was on the right cheek, and that falls on the face. Now, the size of the lesion. That's what we need to do. We need to determine what our size is because there's no point in looking at the codes if we don't know the size. All right, so the formula is for measuring the diameter, the excised diameter is as follows. The size of the lesion, which is 2.3 centimeters, plus the margins times 2. So the margins is 0.2 centimeters. And if you multiply that by 2, you're going to get 0.4. Then we're going to add it together. 2.3 plus 0.4, and that answer is 2.7 centimeters. So now we can go look at the codes. We're in the right section. Now we have to get the right size. And looking, we can see off the bat that 2.7 centimeters falls right here at 11643. All right, so we know that's right, and we know 11642, that's incorrect because it's not big enough. So let's go ahead and let's eliminate A. And that leaves us with B and C. And you know what we need to do? We need to say to ourselves, what is the difference between the two? Well, the difference between the two, one does not have code 12013. And what is 12013? Well, it's saying it's wrong. And it's saying B is right. So let's go ahead and see what 12013 is. If we go to the codes 12013, this is simple repair section. And the parent of 12013 is 12011, simple repair of superficial wounds of the face. Again, we do not code simple closures. The guideline told us that. So 12013 is incorrect, and B is the answer. Yep, it's a simple repair. Okay, we'll review that. Let's do it now. Okay, so let's go to the section. If you got it correct, a lot of you did. Let me go up there and oh my goodness, oh my goodness. I think 100% of you got it correct. All right, so if you go, outstanding. If you go to the table of contents, this is the section for repairs. And repairs are more than sutures, coders, right? But these are your sutures here. But repairs also are adjacent tissue transfers, skin replacement surgery, flaps, grafts, etc. Okay, so now let's go ahead and let's look at the difference between a simple closure, intermediate, and complex. All right, so a simple closure is one layer closure. It's just one layer that they are suturing. One layer, meaning they're just doing maybe the epidermis and a little bit of the dermis. One layer. They're not going underneath and putting layers. Okay, so the key words to identify if it's a simple closure or single layer: simple, single layer. Let me see something. There you go. Now, if it's intermediate, it's more than one layer. And layer is plural. You'll see layers. Also, if a patient had a single layer closure with heavy contamination, if it was contaminated with some debris or something, then that's going to bump it up to intermediate. So you got to pay attention to the documentation. Also, if there is limited undermining of the skin, that's also intermediate. Debridement is not coded separately unless prolonged cleansing is performed. So if you have an intermediate closure and debridement was carried out at in the same site, it's not coded separately unless prolonged cleansing is performed. So the keywords to identify if a repair or closure is intermediate: the term intermediate, layers, layered, limited undermining, heavily contaminated with one layer. Now let's go over to complex. It's more than layers, scar revision, extensive undermining, debridement of very deep wounds such as traumatic lacerations or avulsions. And keywords: complex, scar revision, extensive undermining, extensive wound debridement, and retention sutures. That's pretty complex. All right, what's a retention suture? Well, these are very, very firm sutures that help hold things into place. So when people get abdominoplasties and they make you a six-pack, trust me, they are putting those sutures there, those retention sutures, to make it nice and tight. All right, I hope you know the difference between simple repair, intermediate repair, and complex. Now it's time for an exercise. Dr. C, please and thank you.
Okay, coders, we're all warmed up now. We want to know which codes should Dr. Bill report. A, 12004 and 12035 with a modifier 59. B, 12035 and 12042 with a modifier 51. C, 12035 and 12002 with a modifier 59. Or D, 13132 and 12036 with a modifier 59. Mark cut his hand and arm while working on his car. Dr. Bill applied sutures to both the arm and hand wounds. An intermediate closure of 16 centimeters was placed on the arm, and a simple closure of 3.6 centimeters was placed in the hand. Which codes should Dr. Bill report? Good luck, coders. You have 2.5 minutes to solve.
You all are amazing. Outstanding. Outstanding. Look at this. Okay, let's do it. All right, my keywords. Cut his hand and arm. Sutures. Intermediate closure, 16 centimeters on the arm. And simple closure, 3.6 centimeters was placed on the hand. All right. There's my inventory. We have a hand cut, arm cut, intermediate closure, arm, 16 centimeters, simple closure, hand, 3.6 centimeters. All right. Now, the next question is there a guideline? Absolutely, there's a guideline. We just said it, right? Well, there's a guideline per se, but I think it's more keyword oriented. So if we go to the box in the middle, we see the code series for simple, intermediate, and complex. And based upon our inventory, we're going to be coding for intermediate closure and simple closure because the documentation told us we don't have to determine if these are, what classification these wounds and repairs are. So now we can go ahead and look up our code. And we'll start right here under the repair. Simple repair. 12004. We know this is wrong because this is repair, superficial, open wound of the scalp, neck, axilla. And look down here, we know that we are coding for simple closures of the hand, and this is simple closure of the hand, scalp, neck, axilla, external genitalia, trunk, and or extremities, including hands and feet. But the reason this is wrong is because it's sequencing the simple closure before the intermediate closure, right? Yeah. And also, it's too big. 7.6 centimeters to 12.5 centimeters, you gotta go. Next up, we're going down into the complex repair section, 13132. This is incorrect because this is not a complex closure. We're only coding again for simple and intermediate. So we're going to eliminate D. And that leaves us with B and C. And I've kind of taught myself to recognize these categories. So on site, I can tell this is intermediate, and so too is this. On site, I can tell that this is intermediate and this is simple because the simple code series comes before the intermediate, and intermediate is before complex. That's just a little trick that I do for myself. So if I know that B is coding for two intermediates and C is coding for an intermediate and a simple on site, I can eliminate the correct and the wrong answer and code the correct answer. All right, so let's look at this. If we go to 12035, this is the code for repair intermediate wound of scalp, axilla, trunk, and or extremities, excluding hands and feet. And we are coding for the intermediate closure of the arm, and it does follow in the correct category, 12.6 centimeters to 20.0 centimeters. So we can go ahead and code this. This is our first code, 12035. Next, 12042. This is repair intermediate wounds of neck, hands, feet, and or external genitalia. This is wrong because our hand is a simple closure. It is not an intermediate closure. So let's go ahead and eliminate B that's coding for an intermediate closure of the hand, of the hand. Gotta go. And that leaves us with C. So let's go ahead and do our due diligence. 12002. This is the code for simple repair, including hands and feet, 2.6 centimeters to 7.5 centimeters. We fall right in there with our 3.6 centimeters. So our answer is C. And look at our modifier 59. I'm using modifier 59 for different repairs, and the guidelines tell us to use modifier 59 for different repairs. All right. Okay, I think we got another. I think we got another one here. Oh, okay. And also, so you all did an amazing job, and we're getting down to the wire, but you know what? I'm going to keep going. And if you have to excuse yourself, you may. I just have, let's see how many more. I have 3 more scenarios to go, and I want to get them done because I want you to have this on your playback. All right? But if you have to go, I understand. And you can just watch the playback. All right, the next subject that we're going to bridge is distraction. And distraction means ablation of benign, premalignant, or malignant tissues by any method, with or without curement, includes local anesthesia and usually does not require closures. Now, any method includes electrosurgery, cryosurgery, laser and chemical treatment. Lesions include condylomata, woo, papillomata, molluscum, contagiosum, herpetic lesions, warts, common plantar flat milia, or other benign premalignant, example actinic keratosis, or malignant lesions. All right, so here is the guidance. Make sure you pay attention to your parenthetical guidelines. All right, and be sure to watch in your documentation for benign, premalignant, or malignant. They are not the same and they have their own separate categories of codes. Okay? And finally, that word each. Each means separately. So when you see this 17003, the second lesion through 14 each, you have to code each separately in addition to the first lesion. Yeah. So we'll show you that. But your keywords are here. Now I'm ready. I'm not sure if Dr. C is still here, but if she's here, please and thank you.
I am still here. Of course, I'm here. And the question
Yay!
is, the procedure should be coded as A, 17276, B, 17273 and 17272 with a modifier 59, C, 17273, 17272 times 2 with a modifier 59, or D, 17274 and 17273 with a modifier 59. Two malignant lesions on the scalp measuring 1.1 centimeters and 2.0 centimeters, and one malignant lesion on the neck measuring 2.2 centimeters were destroyed. Electrosurgery was used for the first two lesions, and laser was used for the neck lesion. The procedure should be coded as, good luck coders, you have 2.5 minutes.
Somebody said, wait, I have will. All right, you all have a few more moments. Okay. All right, excellent job, everyone. Excellent. All right, my highlight, two malignant lesions, scalp, measuring 1.1 centimeter and 2.0. One malignant lesion on the neck measuring 2.2 centimeters, all were destroyed. Electrosurgery was used for the first 2 lesions and laser for the second on the neck. All right, so this is how I broke it all down. I said these are malignant lesions. 2 scalp lesions, 1.1 centimeter and 2.0 centimeters, and 1 neck lesion, 2.2 centimeters, electrosurgery on the scalp, and laser on the neck. All right, so that's how I have to, if you can just break it down and make it make sense to you, then it will, right? Yeah. It'll make sense. All right, so any guideline? Well, the guideline that I referenced was the destruction guideline, and it says your key words are destruction, electrosurgery, cryosurgery, laser. So I know that I'm in the right section, and I need to really pay attention if it's benign, premalignant, or malignant. All right, I got it. Now we're at the codes. And 17270 family is destruction, malignant lesion. We know it's malignant because it says that they're all malignant. Then what's under this code, considered in this code, laser surgery and electrosurgery. These are both our procedures and of the scalp and neck. So all of the codes should be in this family, and it's important that we just select the code of the correct size. So I like to kind of compartmentalize mine. I just want to put them so I can see them, especially when there are numbers involved. If you can go ahead and code from this inventory list, that's fine too. But we have 1 electrosurgical procedure of the scalp, 1.1 centimeters, and 1 scalp, 2.0 centimeters, and 1 neck, 2.2 centimeters. So on site, I'm eliminating 17276. This is coding for over 4.0 centimeters. You got to go, A. Also, I can eliminate 1.724 centimeters because it's coding for 3.1 to 4.0. That's too big, too. You have to go as well. D is gone. And that leaves us with B. 17273 and C 17273, both they share that, but the difference is C is coding for 2 units of 17272. I think we know the answer, right? Yeah. Okay, so 17273 we've established is correct because it falls under this size 2.1 to 3.0. All right, so the neck can be coded using 17273. And notice how the neck is sequenced first because it's the larger of the others. So we're going to sequence it first. And next we have to code the scalp. There are 2 different scalp lesions. So if we go to 17272, it is coding for the correct size, any lesion between 1.1 to 2.0. And yes, we're going to code them both. We're going to code each of them. We're not going to code 1 unit. We're going to code 2 units. And the answer is C. So if you said C, outstanding. All right, coders, this is the last thing that we're going to discuss. And this is something that a lot of people, they kind of say, hey, I'm struggling here with this subject. So let's go ahead and let's tackle it. Let's take it by the horns, right? All right, we're going to talk about Mohs, micrographic surgery. All right. So when we are coding for Mohs surgery, the physician has 2 roles, right? Yeah, they have two roles, and they carry them out in the office. So let's go ahead and talk about it. But this is actually how Mohs works. You can see the lesion at the top. The surgeon takes the one layer off, or we call that a stage, takes the layer off, then goes and looks under the microscope. And um, if there's still cells, the surgeon will go back and keep cutting and cutting and cutting until he does not view any cells. So in Mohs surgery, the doctor has two roles. I described one as a surgeon, where he is cutting the layers of skin. The other role, he acts as a pathologist, and he goes to view the cells under the microscope, typically in the same room. All right. So how it happens, the doctor cuts off a layer, and we call that layer a slice or a stage, right? And then goes and does his pathology work under the microscope. And again, he repeats the process until all of the cancer is removed. Now, when coding for Mohs, it's quite straightforward. It is. So that's what we're going to establish right now. It's straightforward. Just so you know, a stage is synonymous with a slice. It's synonymous, right? So if you hear the term stage, it's also a slice. All right. A block is a piece or section of the slice. So sometimes the doctor cuts up a stage so that he can view the cells better, and he cuts them up into a number of pieces called a block. Now, Mohs is coded according to the body area. Important, really important. These codes, 17311 or 17313, this will represent the initial or first stage. So 17311 here, 17313 here. You're either going to start with this code or this code, and these two codes are distinguished by their body areas, right? So if you're coding for the face, you're going to code, let's see, here. If you're coding the legs and arms, here. All right. Now these codes include up to 5 blocks. So all of the codes, all of the slice or stage codes include up to 5 blocks. Now, speaking of all other codes, after the initial cut or stage, you're going to have to code all subsequent stages using the add-on code directly underneath. So if you have, you know, if you're using 17311 for a stage, the first stage of a head excision, like a cancer on the head, then you have to use 17311 first. All other stages will be coded using 17312. The same with 17313 for cancer on the arm. The first stage will be coded using 17313, and all subsequent stages 17314. And all stages include up to 5 blocks. And if you go beyond the 5 blocks, you got to use the add-on code for each additional block. Now your keywords for coding Mohs, well, often it's used, that process is used when you're coding skin cancer. So skin cancer, basal cell carcinoma, you might see the acronym BCC, squamous cell carcinoma, SCC, and melanoma. And this is how you code for Mohs. So my advice, definitely CHUN this section 17311. This is the first stage, the initial stage, up to 5 tissue blocks. 17312, subsequent stages, up to 5 tissue blocks each. 17313, initial stage for the trunk, arm, legs, and this includes up to 5 tissue blocks. 17314, this is each additional stage up to 5 tissue blocks. And don't forget your additional blocks. You code your remaining blocks using 17315. Now, you ready? Let's do it. We're going to code a Mohs coding exercise. Dr. C, please and thank you.
All right, coders, here's one for the road. And the question is, how would you report Dr. Alexis's services? A, 17313 and 17314 with a modifier 58 and 17315 with a modifier 59 and 88314 with a modifier 59. B, 17311 and 17312 times 7. C, 17313, 17314 times 2, and 17315 times 2. Or D, 17311, 88302, 17314 times 3, and 17312 times 7. Dr. Alexis completed Mohs surgery on Ralph's left arm. She reported routine stains on all slides, mapping, and color coding of specimens. The procedure was accomplished in 3 stages, 5 blocks in the first stage, 7 blocks in the second stage, and 3 blocks in the third stage. How would you report Dr. Alexis's services? Good luck, coders. You have 2.5 minutes to solve.
All right, coders, you all are rocking it. Somebody said it was tricky, but you nailed it. You're nailing it. Okay, okay. All right, here we go. Keywords: Mohs surgery, left arm, routine stains, mapping, color coding of specimens, 3 stages, 5 blocks in the first stage, 7 blocks in the second stage, 3 blocks in the third stage. Okay, how are we going to report Dr. Alexis's services? Well, here's our inventory. We know we're going to code from the Mohs surgery section. This surgery was on the left arm. Important. Important. We're going to eliminate 2 answers with this information. I'll let that marinate. The body system is important. Then you have stage 1, 5 blocks, stage 2, 7 blocks, stage 3, 3 blocks. Now, let's go ahead and take a look at a guideline. Here's the Mohs surgery guideline. It says code according to the body area. The first stage is always coded separately. So you only use that once, that first stage. And each stage is 1 slice with 5 blocks bundled in it. And the guidelines say use the add-on code for each additional slice or stage after that first one. And then use the blocks add-on code for any bundled blocks, anything in excess of the bundled blocks. All right. And finally, that routine pathology should not be coded in Mohs treatment codes. Look at that. And we have some routine stains. And we have some pathology codes. Look at that on site. Just saying. All right, so if we look at our inventory, look at this. Stage 1 has 5 blocks. So that means we're not going to code any blocks because 5 blocks are bundled in each stage. Stage 3, the same thing, only coding for 3 blocks, less than 5, so it's bundled. But look at stage 2, it has 7 blocks. So we will bundle the 5 blocks and code only 2 additional blocks. And also, on site, I'm eliminating A because it's coding for that routine pathology, routine slides, gotta go. And that leaves us with B, C, and D. Sorry about this. All right, so I decided that maybe you should write, just so you understand that this code should only be used once for a procedure. And 17313, also use it only once. It says first stage, first stage. All right. Also, the body area is significant. 17311 is used for the head, neck, hands, feet, genitalia. And 17313, we're using that for the trunk, arms, and legs. Where is our procedure? Our procedure is on the arm. So if our procedure is on the left arm, we're going to code 17313, and we're going to eliminate 17311. So we're eliminating B and D. We eliminated the whole thing, and the answer is what? Okay, the answer is C. All right, so let's do our due diligence. That was too easy. Let's do our due diligence. Sorry about that. So if you have a circumstance where you have stages and blocks and stage code, my advice is to do something like this until you get yourself familiar. So put your stage 1 in the stage column and put the number of blocks that was carried out. And then go ahead and assign your stage code. So the first stage will always either be this 17311 or 17313. So that's our stage code. How many blocks? How many blocks in excess? Well, none, because we only have 5, and 5 are bundled, right? So the first stage bundles 5 blocks. So second stage has 2 blocks. So we got stage 2, 7 blocks. And so since it has 7 blocks, we're going to have to do a little more. But first, let's use the stage code. Let's go ahead and identify the stage code for this second stage. Well, we can't use 17313. It's already been used. So go underneath and use the add-on code 17314. For each additional stage after. Now, how many blocks in excess of the bundle blocks? Because if you look at this also bundles 5 tissue blocks too. So if it bundles 5, we have 2 blocks in excess. And finally, stage 3. Sorry about that. I'm a little out of sync here. For stage 3, we have 3 blocks. The stage code that we will use will be 17314. And then we will also not need a blocks code because these 3 blocks are bundled. So if we look, we know that we're going to code 1 unit of 17313, 1 unit of 17314, another unit of 17314. So we're going to multiply that by 2. We're going to have times 2. And then we're going to have to use the remaining blocks code. We've got 2 blocks remaining. And we're going to code 17315 times 2. 2 units. And that is our answer. All right, coders. Who wants to try one more time and that'll end things? How did you do? You guys rocked it. Look at all those C's in there. We had some B's, but hopefully you all understand it, and this is where you're supposed to get your instruction, right? Somebody said, give me another try. You got it. If you have to go, just remember this is our last one, and then we're going to end. But I got one more. And you got it right. Outstanding. All right, Dr. C, thank you.
You got it, Mrs. J. And the question is, what are the appropriate CPT codes for reporting the procedure? A, 17311 and 17312 and 17315. B, 17313 and 17315. C, 17313 and 17314 and 17315. Or D, 17311 and 17312. The physician removes a tumor from the patient's neck using the Mohs micrographic surgery technique. During the first stage, the physician takes 4 tissue blocks and reviews them under a microscope. The exam of the tissue blocks reveals a second stage is necessary to remove areas where the tumor is still present. The physician removes 2 additional tissue blocks. What are the appropriate CPT codes for reporting the procedure? Good luck, coders. 2.5 minutes.
You all rock. Man, outstanding. Outstanding. All right. So I did put my inventory up a little early, but I don't think you needed it. All right. So the physician removes a tumor from the patient's neck using Mohs micrographic surgery technique. First stage, the physician takes 4 tissue blocks under the microscope. The exam of the tissue blocks reveals a second stage is necessary, and that second stage requires 2 additional tissue blocks. So this one is a little more straightforward, right? Yeah, so let's get to it. So if we go and put, I like to make my little chart. My first stage has 4 blocks. My second stage has 2 blocks. But if we go to the codes, 17311, this is a first stage code only for head, neck, hands, feet. Remember, our procedure is on the patient's neck. And 17313, this is the code for trunk, arms, or legs. So it looks like we can eliminate something on site, and we are going to eliminate 17313, right? Wrong body area, and that's easy. So let's go ahead and eliminate B and C. Gotta go. And now we're just going to focus on A and D. And you guys are just saying things in the chat saying, hey, you only need 2 codes. You got that right, because there are no blocks in excess of 5. So you're right. All right. So 17313 includes up to 5 blocks. So that's all you need. And 17312, that includes up to 5 blocks as well, right? So the second stage, there were only 2 blocks, and this includes up to five blocks as well. So you don't need any additional blocks. So our answer, D, 17311 and 17312. Let me know, coders, if you like Mohs, or if there's another integumentary coding chapter that you prefer. Let me know. Let me know what you get. But you should have gotten in week 10 an introduction to our annotation technique called CHUN. Hopefully you did. And make sure you join the CHUN Facebook group. There's so many. We have a CHUN Facebook group if you want to get some demonstrations or advice, go and join our CHUN group. All right, you should have had a brief discussion on AMP of the integumentary system. We discussed how to code excision of lesions, how to code those repairs. We also took a stab at destruction procedures, no pun intended. And we ended things with Mohs micrographic surgery. And hopefully, coders, we brought you one step closer to CPT coding mastery. Now it's time to discuss the homework. All right, so to get the homework, if this is your first time watching, go ahead to our website, www.amcicoding.com, click on YouTube course, and you're going to look for the syllabus. Coders, not coders, team, put the syllabus link in the chat if anyone needs it. You don't have to go to the website. The syllabus link is in the chat. When you get to the web page, read everything, then scroll down, you'll find the syllabus here. When you click on that syllabus, you'll see the books at the top. Then you'll need to scroll down to week 10 and do the following. Number one, the class PowerPoint for this playback is available in Discord under resources file or handouts. Number two, go ahead and watch the playback. If you need to watch this playback, you can find it here on that green link. Number three, your reading assignment. Go ahead and read chapter 13. This is surgery guidelines. You definitely need to understand the surgery guidelines before you begin studying for surgery. So, surgery begins in integumentary, but make sure you read these guidelines. Also, number four, go ahead and read the chapter on integumentary coding. Inbox. Number five, we provided you with an additional lecture on integumentary coding. So you're going to bridge some topics that weren't discussed in this lecture. Number six, complete the MCG exercise, the integumentary exercises, or those integumentary um, quizzes. So you just go to your MCG 2024, 2025. If you have the 2025, click on charts, videos, exams, and additional resources. Click on that link and you'll see these and select the exams and you'll see integumentary system. And finally, number seven, go to Friday Night Live. Definitely go to Friday Night Live. And next week, we will discuss CPT, musculoskeletal, and respiratory systems. Remember that. Okay, thank you so much for attending. Hopefully, you got something from this. Let us know. You know what? People are getting this survey link late. It's a quick survey, quick. If you complete this survey, it helps us help you, right? So please take a moment and complete the survey. If you liked it, let us know. If there's something we can do better, let us know. Now, coders, if you're saying, "Hey, you didn't discuss all of the topics in CPT Integumentary," we just can't. There just is not enough time. However, you can do the rest on your own. You can do it. All right. Week 10. This is the end of week 10. If you liked it, please like up this lecture. If you didn't, thumbs down. Let us know. And as we close out this class, I want to take a moment to honor the incredible AMCI team who pour their expertise, their heart, and their dedication out into every lesson. Thank you so much. Thank you, interns. You are the heartbeat of AMCI. Encoders, don't be afraid to fail. Be afraid to not try. Okay, coders, go study, go practice, and go be great. We'll see you in the next session.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI. AMCI.